Welcome, everyone. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, I'd like to thank you for joining us for the third webinar in a specially designed health communications e-learning series funded by the Delta Dental Community Care Foundation. Each presentation in this e-learning series is being recorded and will be available on the TexSOC website 2 weeks after presented as a live webinar. In the lower right corner of your screen, you should find the chat box where you can type in any questions you have throughout the session. The presenter may stop along the way to take questions, but there is designated time at the end to address your questions. If you would like to receive dental continuing education credit, instructions will be given at the end of this presentation. Please be prepared to write down or copy-paste the course code and evaluation link from the chat box, or use the QR reader from your mobile device if you have one. We will enter the evaluation link and course code in the chat box towards the end of the presentation. This learning series is a product of the Texas Fluoridation Campaign, a collaborative partnership between the Texas Oral Health Coalition, the Texas Health Institute, and the University of Texas Center for Health Communication in an effort to provide detailed information on how to create successful health messages to improve health outcomes. The amount of oral health data continues to grow, but are we using and translating it in ways that educate and inspire action? In today's session, Making Data Count, attendees will learn how to choose and present oral health data to enhance lay audiences' understanding and influence policymakers. To learn more about any of these presentations in these e-learning series or take a previous course online, please visit the education page on the TexSOC website at www.texsoc.org. Our presenter today is Matt Jacob, who many of you know and have worked with over the years. Matt's efforts in communications have been recognized or honored by a variety of organizations, including the Association of State and Territorial Dental Directors, National Public Health Information Coalition, HealthLiteracyMonth.org, and the New York Times. He graduated with a bachelor's degree in journalism from the University of Arkansas in 1985 and previously managed communications and marketing activities for the Pew Children's Dental Campaign and the Children's Dental Health Project. Matt is known for translating complex scientific content into messaging that is clear, concise, and compelling, and most importantly, comprehensible to policymakers or the lay public. For more than 20 years, Matt has helped nonprofits and advocacy organizations raise the profile of their issues, particularly in the areas of health and education. It is my pleasure to introduce you to Matt Jacob. So Matt, it's all yours.
Thank you so much, Beth. I really appreciate it. And I want to thank the Texas Oral Health Coalition for sponsoring this series. So today, as Beth mentioned, we're going to focus on data, making it count, and not just making it count for select audiences, but making it count for much broader audiences. Before I jump into the topic, though, I do want to share my disclosure. I do have no financial or familial relationships to any of the agencies, products, or brands that are referred to within this presentation. So without further ado, let's take a look at the context in which we are operating and living. There has been a tremendous data explosion in our country. The growth in healthcare data just keeps right on. To give you an example, consider this. So this is the billions of gigabytes that were required to store data in the year 2013. Look at where it has jumped in just the space of 7 years. So what this represents is 2,314 exabytes. I'm not sure if you've heard that term. Until I read this article, I wasn't familiar with exabytes as well. Well, an exabyte is 1 billion gigabytes. So this is an awful lot of data. We're sharing data, we're collecting data, we're analyzing data at quite a pace. And so the real question is, what do we do with this data and how do we make it more meaningful, not just to our peer groups, in our associations, but how do we make it more meaningful to key decision makers, to patients and the public? I believe, as a data specialist at Michigan State University, believes that this is a part of data literacy. You know, we tend to think of data literacy as the ability to comprehend and analyze data, but it's also to communicate effectively with data. And I think we have to consider that, you know, one of the requirements. It's not just an afterthought. We really need to be able to translate and communicate that data. And then this is one of my favorites. There are times when we tend to approach data as if it were the story, just sharing a table, sharing a chart. But the truth is that the story is the story, right? There's this larger story about oral health, about public health and wellness, about disease prevalence, about certain pockets of our community that have unmet needs that just aren't being addressed. So data can help us shine a light on that. The data, though, we don't want to get lost in the data. Let's use the data as our ally to help to shine a light on unmet needs, on ways in which access could be improved or maybe has been improved, et cetera. So the data is evidence that can support what we say when we reach out to patients and the public. So here's what we're going to cover today. We're going to explore these 4 areas: how to be strategic in sharing data, simplifying data to make sure that the public and policymakers understand, aligning data with your audience. It's a very important consideration. And then finally, we're going to look at data visuals. And I would sort of say the good, the bad, and the ugly, because there's a lot of diversity out there. I want to pause for just a moment, though, and clarify that when I speak of the public, I am including policymakers. And I say that for this reason. I think that there are definitely some policymakers with a tremendous knowledge of public health and oral health. There are policymakers who understand how to process and interpret data. But I've also met dozens and dozens of city council members, local water utility board members, state legislators, and others in positions of authority who really had a relatively low level of health literacy and data literacy. And so it's with that in mind that I think that the presentation I'm doing today hopefully will go well beyond enhancing knowledge by the public, but will help also with policymakers. So first, let's look at how to be strategic in how we package and present data that we've collected. First, right up top, less is more. I think sometimes we can overload people a little too quickly, throw too many facts and data points and statistics at them. So I think really when you have a fact sheet, an FAQ, a one-pager, some kind of health promotion handout, you're better off sticking with no more than 3 data points. It's great and it's fine to have links that take people to web pages or other content with additional data. It's great to be able to point people to a report that's more comprehensive where they can find more data and dig in. But viewing these kinds of documents, fact sheets and FAQs, as an introduction, as basically an invitation to learn more, is the best way to approach them. And if you overload them with 8, 9, 10, 11 different statistics, it's very hard for your readers to walk away remembering any one of them. And then, of course, using the data that your audience needs to know. There may be a lot of things you could tell your audience, but what do they really need to know? What do they want to know? I think ratios are something that we tend not to use nearly as much as percentages. And I understand when you're doing tables and charts, they tend to be set up that way. But I think expressing percentages as ratios can be a very helpful way for parents, for the public, for people out there to put things in some context. So when I hear 1 in 5 kids, for example, I came from a big family. I have 4 brothers and sisters. So, you know, when I hear 1 in 5 kids, I'm thinking, wow, that was one of us, right? So, you know, I think that people, when they hear a ratio, they think in terms of their household, their neighborhood, how many kids are on their street. It provides a context that makes data suddenly come alive in a way that it may not if you just say 19%. So it's something to consider. This is something that a lot of organizations who work in public health do, and this is one example, putting it in context again. The percentage that equals 1 in 7 is what, about 14, maybe 15%? That just seems very small. But saying 1 in 7 men, I think, puts that in a really helpful context for people to realize this isn't just about women. So, it affects both genders. Likewise, I stumbled on a study recently that I thought was really interesting and helpful to understand the access barriers that exist in oral health. And so one of the ways I tried to put it in context was to use this statement. 1 in 20 may not sound like much, but that number equals all adults living in Arizona and Massachusetts. So I don't know that how well that's going to work with everybody, but I think sometimes it pays to try and find different ways, alternative ways to express data as opposed to just saying, 6% or 5%. It's also important to choose data that makes it real for people. So there are a lot of statistics you could use to summarize the study that was released in late 2018, looking at the impact of ceasing water fluoridation in the capital city of Alaska. You could have said that dental treatment costs rose 47%. You could use a lot of stats, a lot of percentages. But this one stood out to me, and the lead author of this study, I thought, really put this in context. So if I'm a mom or a dad living in that community, this is real to me, right? My child is likely to have one more cavity procedure every year at a cost of about $300 more. That makes it real. That really demonstrates how connected it is to our real lives. Now let's turn to aligning data with the audience's needs and its literacy. I love this statement. We are usually the disseminators, the deliverers of data, but Dr. Evergreen here reminds us that it's helpful for us to put ourselves in their shoes. What are the challenges of being a consumer of data, and how easy is it to really navigate and interpret? So here are 5 questions that I think are very important for people before they take a surveillance report, lots of data, and rush out there and say, hey, everybody, here's the data, here's what we found. First and foremost, what is their level of health literacy, right? That's going to vary somewhat, maybe significantly, from one audience to the next. You also want to ask yourselves, what do they already know or believe about the topic, right? So you hear people often talk about the importance of meeting people where they are. Answering this question helps you meet them where they are. Third, what is their lived experience with the topic? What have they personally experienced in their states, in their communities? Are they likely to be surprised by your findings? Will it shock them, or will it seem very predictable? It's worth pondering that as well. And then finally, what is your objective for this audience, right? So what are you looking to accomplish? The way you present the data and how you come out of that and kind of cap off that presentation or that document or report that you're producing is going to be shaped by this. It should be shaped by this. What is your objective? Do you want to simply change how they think, how they behave? Do you want to enlist them as a partner and get them involved in some way? Is there a key role they could play? So these are important questions to ask before you simply kind of get caught up in the typical dissemination and replication of data. Assessing the audience's literacy level. This is a generalization, so I just want to put that out there. Obviously, literacy levels can vary significantly within the public, within policymakers, within all of these groups. But generally speaking, we see this kind of continuum, right? And again, I think that the average policymaker has higher health literacy than lay audiences. However, many of them fall into lay audiences, and there's an awful lot they're not going to be able to decipher. So using terms that they understand when you produce a fact sheet, when you summarize the data, I understand a lot of charts, a lot of tables, built into it, your data people gave them to you. They're going to use terms like mean or median, but a much better term to use for the public and even for health journalists and policymakers is average. Pretty much everybody understands what that term means. There are many people that can be easily confused by mean or median. And this gets tricky too, right? When people say, well, these trends have an inverse relationship. What does that mean? A lot of your audience is not going to understand that. It's better to say these trends move in opposite directions. And then a term that we're all familiar with, health departments, state and local, are regularly collecting data. We call it surveillance data, but in the age of the NSA, that term can be misinterpreted. It can confuse people. So it pays with lay audiences to simply say, this is data that's collected annually or regularly by the health department. Terms like longitudinal, what does that mean? Many health journalists who have covered health for a long time are familiar with that term, but some of them are not. And sometimes the person who's assigned to cover an oral health or public health issue may not regularly work in that field. I remember talking years ago to a New York Times reporter. You would think the New York Times, when they're working on a healthcare related story, they're always going to have a health journalist work on it. Wrong. This journalist I was talking to normally covered real estate trends in Brooklyn. So wrap your hands around that, right? I'm not sure longitudinal study meant a lot to that person. So I took a little extra care to walk them through the information we were sharing. So why not just simply say, hey, we studied a group of 524 women over a 10-year period. So just spell it out and resist the temptation to use terms that are not likely to be understood by a lot of people. I think this is a good example too of where terms that have a certain context and usage within the research field have a very different understanding in popular culture. So here's a study that concluded that there was a positive association between periodontal disease and preterm birth. Well, obviously it wasn't very positive, but within the context of statistical data and expressions, this term makes sense. But again, if you're going to translate this term and you want to talk about this study to women during pregnancy or women of childbearing age, probably want to use different language. It's also important to choose data that are relevant to your audience. They want to see themselves in your data. So whenever possible, if you can break it down and disaggregate data, it's really important. That's where you start to see gaps. That's where you see disparities. And in an era where we really continue to talk about health equity but struggle to make progress, we have to hold ourselves accountable. So this is very important to shine a light on where there are gaps, where there are disparities. And even consider mapping. You can sometimes, some data people can actually draw maps of a city or a county that will display some of those variations. They may be uncomfortable things to show, and they may, in many ways, present and point to the problem, but you've got to start somewhere. And so if people aren't feeling in their neighborhood or their city what you're talking about, that's going to be a problem. So again, breaking it out so people don't just think, hey, the average third grader in our state has X problem or has X health status, right? So, but what about people of different races and ethnicities and income levels? Asking which data will matter most to your audience is really important. And here's an example of this. So I mentioned this study earlier. This was published in 2018 by BMC Oral Health. It's the study of Alaska. And you can pull very different pieces of this study out and understand how they would be more relevant, more meaningful to certain audiences. Let me give you an example. So if you're talking to the local Children's Alliance, an advocacy group for children's health and education, you might want to show them how cessation particularly harms younger kids' oral health. And you could do that by citing this kind of language. You'd obviously want to interpret it, would probably want to use cavities or tooth decay instead of caries, but this is a statistic. The average number of procedures was significantly higher than in a community with fluoridation. So this is really something to pull on. What if you're talking to state legislators? Particularly now, we know that state budgets are a mess because revenue has really dropped off, tax revenue and other forms of revenue. And so states are going to have to make some very tough decisions that could lead to calls for cutting back on adult Medicaid, for example, adult Medicaid benefits, particularly in dental. This sadly happens from time to time. So there's a value in pointing to the cost impact, right? So to be able to say that after stopping fluoridation, inflation-adjusted costs for dental treatments went up 47%. So, that is something to point to, right? For that audience, being able to show them that oral health prevention doesn't cost, it saves, is really important. Suppose you're talking to dental professionals. They're an important audience too, and sometimes you're going to translate research and data for them. So revealing how other forms of prevention are not a substitute for community water fluoridation, right? We don't want to get ourselves in a situation where we're kind of pitting one against the other, right? All of these forms of prevention have value, but this is an interesting thing from this study. So the dental treatment cost rose dramatically, even though there were efforts made to increase sealant placement. It can be a nice way if you have dental professionals that may not, some who may not understand or may not see the big impact of community water fluoridation. This is one way to highlight it. Analogies help as well. I tried to use an analogy earlier. The one about Arizona and Massachusetts. Here's another analogy. This was published in USA Today about 2 or 3 months ago, when COVID was just really starting to take off. And it's a really simple way. Somebody who looks at this headline and that photograph gets it, I think, right away. Especially if you're from New England or the Boston area, that's a lot of people, right? Wow. It could fill all of the seats in this baseball stadium. So those analogies can come in handy, particularly when you're talking to non-clinical audiences. Analogies can be helpful, but you do want to be careful. It's always good to vet your analogies internally before jumping out and using them more publicly. Here's an example of this. I don't know if any of you happen to see this. So about 2 months ago, 2.5 months ago on Fox News Sunday, the host, Chris Wallace, was having a conversation with Dr. Adams, the U.S. Surgeon General. And this was a statement that Dr. Adams made. He was trying to put the COVID-19 situation in some larger context. I don't think it was a great analogy, and I suspect afterwards he even rethought it as well. But this was something that the host responded to very quickly, right? There's a big difference here, isn't there? People can choose to use or not use opioids or cigarettes, but coronavirus, it's just something you catch. So I think it's good when you have an idea for using an analogy, vet that with your peers, just get their feedback and don't go running out with it. You want to make sure that you feel as though you're on solid ground. Let's pause for just a moment before I get into the challenges of simplifying data. And I don't know, Beth, if there are any comments on the chat board, any questions that people have?
Well, I'm not seeing any questions, but I did have one. Going back to what you were recommending at the beginning, know the health literacy of your audience. Is there, or are you aware of another way that you can determine or gauge their health literacy without doing a pretest?
Yeah, that's a great question. I don't know of any simple tool that you can employ to use that. What I would say is that it can pay to, for example, health journalists. It pays dividends to read those articles in your local newspaper, read what is being written about health and medicine, and you can get a pretty good sense based on the language that's used, based on how stories are treated and framed, what kind of knowledge there may be among the journalists that are writing for the paper, as well as for broadcast and local coverage or websites. It can be trickier with policymakers, and a lot of times, I think this is why it's great when oral health organizations and associations organize a lobby day, you know, an event where they go to the state capitol, they sit down with legislators, they talk with them. And a lot of times, you know, we have sort of a presentation, you know, a particular ask or something we want to say. But I think one of the best things to do is also to ask a question or two of the legislator. And just that can help get a sense of where their knowledge is, you know, and, you know, tell them some things that you think they may not know and might be surprised to know, like that tooth decay is the most common chronic disease for children and teens in the United States. You know, a lot of policymakers don't know that. So sometimes it's something from afar that you can see, but a lot of times it will require some interaction, right? Because we don't want to go in with assumptions, you know, and as I said, you know, it's very easy to say, well, here's where the public is. The public is incredibly diverse, right? So some people who we think of as lay people actually have a fair amount of knowledge and others very little. So, you know, I wish there was an easy tool, but you've gotten me curious, Beth. I'm going to dig around a little bit, and if I find something interesting or helpful on that front, I'll circle back.
Okay, well, thank you, Matt. Those were some really good, the tips to use. So thank you.
Great.
And I don't see any questions, so go ahead and continue, if you will.
Will do. So a lot of times we are trying to take data from deeper reports and pull it into a fact sheet, an FAQ, maybe an issue brief that's 4 or 5 pages at most, right? We don't really have a lot of space or time for tables or charts. And if we do use them, they need to be fairly simple. But also the numbers we use should be as simple as possible. And so this is one of the simplest, but I think best rules I've seen, and it's considered a best practice. And you'll see here, this was an excellent article, a blog that was written about the importance of oral health and how it's becoming more of an issue and health systems are looking at it. But look at the statistics that the writer shared. Medical costs were 29.8% lower for diabetics and 19.8%. All of these numbers could easily have been rounded up to 30, to 20, to 38. I was talking several years ago to a cognitive scientist who told me when the public is presented with a 17.3 or 21.7 kind of number, one of the reasons it's so hard to remember is because you're actually asking them to remember 2 numbers. That's kind of how their brain processes it. You throw that decimal point in there, and they're trying to remember what's on the left side and what's on the right side. And it kind of made sense to me because I know it would be a lot harder for me to remember these. So why not use 30? Why not use 20 instead of 19.8? And why not use 38? So using whole numbers, unless you have a really, really good reason for using decimal points, makes sense. I understand maybe in specific detailed charts and in the original source data, you may still use the percentage points. I get that. But you know, when we're translating it, let's make a different effort. Infographics, fact sheets, again, definitely places where you want to simplify the data. So this is a study that I think most of us are probably familiar with. This was a North Carolina study, and it was of children with recent dental pain and the impact it had on school attendance. And you could word it this way. This would be accurate, but it's a lot of words. Now, what if you simplified this, right? Absent from school. The last portion of this, I think, is something that most readers are going to understand. You know, there's strictly speaking, if you say X is more likely, you kind of want a more likely than who, more likely than what. But I think the understanding here is then people who don't have recent dental pain. I think we don't always have to spell that out so thunderously. So if you take those words out, you've shortened this quite a bit. It leaves room for you to add another bullet point or increase visuals. I also think it's a good idea, unless you're writing a report, a more formal, lengthy document, a scientific document or journal article, I recommend using present tense because that's what people are concerned about, right? We're interested in the here and now. And the truth is, do we really believe that just because that study was, 8 or 9 or 10 years old, that means that it doesn't in any way apply? No. I think we do think that remains relevant. So why not just say are? Children with recent dental pain are almost 3 times more likely to be absent from school. Let's not get too hung up by the details. And I think also just visually, if you're creating a fact sheet or an FAQ, people are going to remember a number when it appears in the form of a numeral. So that's something I think to take into account as well, rather than text. Is the qualifier needed, right? So if you run the numbers and the statistics, it's almost never going to be exactly 3.0000 times more, right? It's probably going to be 3.12 or 3.08 or so, again, we can qualify ourselves to death in almost or nearly or approximately. I think for the purposes of a fact sheet, I think it is fair game to just use R 3 times. So, consider that as well. We don't want to splice and slice every statement in utter detail. Let's look at visuals. I think that's something that is important for us to have on our radar screen, right? I see a lot of infographics. I see a lot of charts and tables. And some of them look super or easy to kind of download. Others are a mess. They're confusing. It's very difficult to make sense of them. Let's kind of take a look here at the good, the bad, and the ugly. So I think that, you really want to think first and foremost before you decide, oh, we're going to throw in a visual, we'll put a chart here, we'll put a bar graph over there. Do we have a chart? Do we have a graph? Do we have a table that will make sense to people? If not, can we translate it? Can we adjust this? Can we revise it so that people get it? And I'll give you a few examples here. I think almost all of us, I'm going to be presumptuous here and say, I think probably most of us on this call have seen this kind of pyramid of the scientific evidence, right? In some different form. Black and white, color-coded, and I think we get it. And so when we see this, we understand it, it resonates with us. But if you're a layperson without high health literacy, without a high reading level, a lot of these terms, a lot of this language is just not going to make sense. And so I think, I've heard people, who said, oh, well, I use that, but don't, it's okay because I take 2 or 3 minutes to explain it. And I don't know, here's my philosophy. A graphic that needs more than 30 seconds of explanation, it's too complex for your audience, right? Because the whole point of a visual is really for people to look and go, yeah, okay, that makes sense, right? The whole reason why you're providing some kind of graphic element is to make it a simpler concept for people to digest. So really thinking strategically about this, I think, is something that's very important. Some other considerations to think about, right? So software, there's lots of different software out there that makes it easier to create graphs. And, some graphs are obviously going to be better for analyzing data internally than for communicating it. So keep that in mind. You may have a graph or a table that an epidemiologist, your policy analyst, someone on your staff finds very interesting as a way of communicating among peers within that internal audience. But jumping outside of that, leaving that office and talking to more diverse audiences, it can be a challenge to communicate that. So there's some basic best practices. Every graphic or chart should have a title that makes it very obvious what's being rated, what's being measured, what's being displayed. Right? And a lot of this is just 101, right? Each axis of a bar graph or chart has to have a label or a brief descriptor. Don't assume, oh, they'll know what that means. You know, I've heard that phrase a lot, and a whole lot of people won't know what that means. Don't make them search, don't make them guess, make it as clear and obvious as possible. And then you want to identify and define all symbols, the line styles, the colors. Again, don't assume that these are self-explanatory. That's an easy thing to say, but it's not always accurate. It's an assumption we really want to avoid making. Here's one I ran into. I stumbled on this graph about 2 or 3 months ago, and I was just kind of astonished because what you are seeing is literally what I saw. There was no chart that told you what the light blue and the darker blue or the medium blue colors equated to. You had to scroll quite a bit further down the web page to find that. That information should always be right adjacent to the map or the table or the chart, and it was not here. So you really had to kind of search for it. Not a great situation to be in. And the other thing that occurs to me is, you know, some of these states, if you're trying to compare and you've got a state that is, say, well, let's just look at something like Missouri and Kansas. So right now, I think that the shading of those states, it's different enough that you can tell they're at a different level or measurement. However, what if you're looking at this on your smartphone? And we know more and more people are accessing a whole lot of data, a whole lot of information and charts. They're on the go, they're on the run. A lot of people are using their smartphones to access reports and web pages and so on. And so looking at this on your phone, the resolution will probably not be as crisp. Would you really know? Would it be obvious right away that Missouri had a different rating than Illinois or Kansas? Maybe, maybe not. I think there should be more of a distinction there in as far as how those are represented. So there's not an easy to see scale telling us what's the best, what's the worst rating, and the color coding does not make it easy to distinguish one state's rating from another. Most people will discern properly, but you just don't know. You don't want to take it for granted. And what about small states like Delaware, like Hawaii, that are set off from the rest of the map? It can be hard when they are set off or they're very small to tell what their color coding is. So keep that in mind as well. Here's a much better way to execute this, right? So here you have, this was from the Louisiana State University. This was something they did on environmental health policies, and they ranked them most healthy to least healthy. And, you know, this is very clear, I think. I don't think these color shadings are as likely to be confusing. You see, first and foremost, an easy to see scale, right? You see a header, every state ranked by healthiness, and it tells you immediately what year the data is from, 2018. You also have color coding that does make it easy to distinguish one state's rating from another. Part of that is they don't rely on simply one family of color, blue or green or any other, to do it. They're using a couple of different colors here, and that helps. I think the previous map I showed you, it was all in blue, and so it limits your ability to provide gradations of shading. When only 2 colors are used, experts say it's best to use a neutral color for the second category, either a gray or a pale beige, something like that. You know, there are certain colors, certain hues of color like green that people who have color blindness, people can be prone to misinterpreting what color they're looking at. And so this is something to keep in mind. And so that's one reason why there's a recommendation by people who really studied this and looked into this to use a second color that's more neutral. You also want to make sure that you're not using any other kind of graphic or marking, or there's anything else going on in the map. So this was something that I saw it was an oral health related website called Scope of Practice Policy. And a lot of great information, but one of the things that I just didn't really understand was there are certain certain states that had little swatches of white, look like wings, sometimes dots. You know, you look at Nevada, right below the abbreviation in Nevada is a little a horizontal little tail there. In New Mexico, you see what looks like a large paper airplane. You know, I could never figure out what do those colors mean, and is that just a stylistic thing? Is that calling my attention to something else? I hovered my cursor, you know, I put my mouse right over them to see if something would pop up. Nothing did, so I couldn't make head nor tail of what those were. And I think I'm not alone. I think a lot of people coming to that site would wonder as well, what does that mean? Is there additional information? You know, so don't tease your audience, you know, again, making sure if you're going to put marks on certain states that it should be clear what they're signifying. And I don't know if this was a mistake or what it was. Pie charts, very popular. A lot of people make them when they're doing slides and they're doing PowerPoint presentations and so on. So, you know, it is, you know, you see the header there, the cost of an education, that's good. You also see that the percentages are labeled, right? So they don't just have a kind of orangey brown color. They tell you that represents 61%, which is important to do as well. It's best practices too. National Cancer Institute has a great document that it put out in conjunction with NIH called Making Data Talk, a workbook. And I'll reference the link to it later on in this presentation, but it's definitely something worth checking out. So they recommend that you limit the number of slices within a pie chart to no more than 5 variables. When you get more than 5 things on there, it can be difficult to kind of distinguish and understand, you know, which one is which, and it becomes a lot to throw at people. You also want to align the largest slice of pie vertically with the very top of the pie chart. And this is what I'm talking about, right? So that 61% sort of starts right at 12 o'clock and moves around. Pie charts, though, you know, there is the good, the bad, and the ugly, I said, and that's true for pie charts as well. You know, this breaks that rule about limiting the number of slices. You know, this isn't 5, this is a whole lot of them. So Towards Data Science is a website, and they posted this pie chart very early when the COVID-19 pandemic broke out. This was in early March, and this was some initial data that they were showing everybody. Again, they not only go to points, they go to 2 numbers beyond the whole number. So instead of just saying 6 or 5.6, it's 5.59. I'm not sure how helpful that is. It actually makes it harder to fit within the slice. And there's no way we can tell the differences among many of the countries because the slices are so tiny. There should have been some strategic consideration of that as they were putting this together. So if you're trying to display a whole lot of different statistical variables, there's nothing wrong with that. But a pie chart is probably not the ideal vehicle for doing that. You know, I've used them, a lot of people have used them. 3D versions of pie charts look pretty cool, right? They're not flat, they give your slide some dimension, they look, you know, they just look a little different, a little cool, you know, why not try something a little different, right? Here's the problem. Depending on what you're depicting, how many variables they are, 3D versions can have the effect of obscuring or minimizing differences that are there. Let me give you an example. We're looking right at it, right? So this was an analysis that was done of the most common reasons for charitable giving. So they surveyed people who were regular charitable givers every year, and they asked them, what motivates you? And these were the reasons that it kind of broke down to. Now, it doesn't look like there are any huge differences here. Yeah, the blue looks largest, but you know, look at the difference between this representation and this representation, right? Personal values, it's double what the other choices were. People were twice as likely to say their personal values were shaping their reasons for giving, that were really their motivation. Look at this again. That's the 3D chart. And this is the bar graph, right? So I think that that pie chart, it looked cool, looked interesting, right? But it had a tendency to, I think for a lot of viewers, people who aren't looking closely, it could mask the difference, the very real difference there is between the four responses. So just keep that in mind as you're thinking about how best to represent data. Like I said, title or header, you really want that, and you've got it. You know, this is a really good, clear thing here. And what's even better is they don't just say measuring happiness during the crisis. It tells you the conclusion. And so this is counterintuitive, right? For those of us who think about the scientific method, you start with a hypothesis. We tend to be very sequential. Well, first I'm doing this, and then we collect the data and so forth. We think more sequentially in public health. And really your title should start at the end. It's really your conclusion. There's a big drop in happiness right now, especially for lower income Americans. So starting with that, right? So if nothing else, even if people were not able to decipher your chart, they at least get the takeaway. It's very clear. I think that's important. It's also important to, if there's kind of a subhead or a key takeaway, it's this, right? The gap between rich and poor Americans' happiness has expanded, right? So having that language to the right, and shading that last part of the scatter plots, I think was a really good way of bringing attention to that. So I think this graph does a pretty good job of not throwing too much at you. You could argue that maybe the term median, you know, there might be a better way to represent that depending on the audience you're presenting this to. But they do a good job of highlighting the key takeaways and keeping the data to a manageable level, not throwing 5, 6, 7 variables at you. I think this is also a good visual for data. You know, the X and the Y axis are pretty easy to understand. This is the number of COVID deaths in nursing homes. You see the dates. They tracked it day by day. This was back in late April in Massachusetts. It makes it pretty uncomplicated. They only are throwing two variables at you. This is the COVID-19 deaths in nursing homes, and this is all other COVID-19 deaths that occurred. So they also have the label is there, the subhead is there, you know, and they give you the takeaway, right? The cumulative number exceeds the number of COVID-19 deaths elsewhere in the state. You know, this is really the big epicenter at that stage was nursing homes throughout the Commonwealth of Massachusetts. So it's pretty clear. I don't think you have to search very hard. You know, if I were presenting this to a lay audience, I might say total instead of cumulative, right? The language, that's something we've got to work on. But on the whole, I think this was a good visual. All right, I talked about the good. Now we're beyond the bad, and I think this is plain old ugly. This is just a real mess here. And this is in Wired magazine, which is, you know, a real cool magazine. The tech industry loves it. It's, you know, you can really dig deep into stuff, and boy, you would have to dig. You'd need a very large shovel to get through this. This is just a whole lot going on. I think the creator of this just, you know, in the Olympics, they say there's a degree of difficulty for gymnastics and swimming and all these things. Well, this had a high degree of difficulty because you're trying to cover a lot of different things. The FIT, the FIT, that's a totally different statistic. It's not easy to define. I would struggle to tell you what that means. Natural log of number ratio, you see that is the label on the left side. Again, they never define it. They never tell you what that is. They don't attempt to break that down. And so what you've got is you've got two different numbers from every single country. So there's the dotted number, and then there's the solid line. And I think it's just very difficult without some more help to know what this means, to break down for audiences what is the FIT and, you know, all of this stuff. I think a lot of people are just not going to know what the y-axis, the left side, is actually measuring. And then, it's always nice to try and use photos or some other graphic art to kind of complement a data visualization, but this is a real train wreck. And the main reason, I think we all get right away, right, is you can't really read the header. You have to concentrate to see that it says current asthma prevalence. So they haven't thought about the background, that green is not the right color to try and contrast with a kind of moderate sandy colored background. It's just not going to show up well. The right side of the header looks good, but the left side is very difficult. And there's so much competing with our attention these days that if your readers have to stop and study and look closely and take their glasses off, they're going to move on. They'll move on to something else. The other thing is you see the 3 sets of bars. They're color coded. That's good. And they're labeled age, sex, and race ethnicity. However, best practices would say move those clusters a little closer together to reinforce that those 3 bars are associated, right? They're meant to be viewed kind of in the same cluster. Likewise, male, female, right? That's really a distinct subset of data. And the last one on age. So, moving those vertical bars closer together would have been just a better way to not make it quite so compressed and to make it clear what's going on. Also, rounding out the percentages. Do we really need to know it's 10.3 versus 8.5 and 7.1? Again, I would round up numbers here. There's no need for it. You can have a link to more information for those who want details. The labels would actually be easier to read, I think, if those bars were displayed horizontally and not vertically, right? So we could see child, we could see adult, male, female, and so forth. So think about that as well. Sometimes your initial instinct is to display it in a way that isn't going to look as good. An additional resource for visualizations, graphic visualizations, data. This is a hyperlink. You'll get a copy of these slides afterwards or can access this, and that link will take you there. A lot of design software, again, it can really help you out, but it's not going to solve your problem if you see the data itself as your story, and if you overlook your audience's knowledge and needs, and if you throw too much data too quickly at your audience. Let me talk just briefly about advocacy as we kind of turn the corner and wrap up here. Advocacy, data can propel those efforts in meaningful ways, right? It's not just about sharing information, but really moving an agenda, shaping public policy. In San Jose, about 12, 13 years ago, there was a local nonprofit health organization that actually maintained pediatric medical and dental clinics, and they pointed to this data point as a way to call attention to the unmet need, the tremendous disease level in the metro area of San Jose, and these stats were key in starting a conversation. Data has tremendous power, and this was a way to do it. Think about the creative ways you can present data if you're looking to advocate, if you're looking to bring an issue to the forefront. There's been a lot of work over the past 12 months by advocacy groups calling attention to opioids and the carnage that the opioid crisis has had in this country. So, data can inspire visuals that will get the attention of media and policymakers. Think creatively about it. Suppose a quarter of older adults in your state had lost at least 4 teeth. Is there a way you could turn that into a powerful visual? It's worth thinking about. Creativity connected with data can do some powerful things. It doesn't have to be new. Your data does not have to be brand new to make a difference. This was a report that I worked with our team at Pew back in 2012. Most of this data was at least 3 years old, but reporters weren't aware of it. Policymakers weren't aware of it. It was kind of quietly being published in issue briefs and reports and institutes, and we brought it to the fore. We consolidated it and looked to kind of bring attention to it. So I'm going to wrap up by pointing toward a few different resources I think are excellent. CDC has online health literacy training, and there's a component of that that is data specific. Think about that. Making data talk, I think I've already referenced that from the National Cancer Institute. They are the National Cancer Institute, but believe me, the lessons, the insights, they apply to all health issues. And then NACCHO has a great tip sheet on presenting data, and here's a link to that. I definitely encourage you to explore that if you can. So I'm now open for questions or comments. Beth, if there's anyone who has a question, I'm certainly ready to hear it.
Okay, thank you, Matt. We do have a question from Bev, and she wanted to know about the best type of font size and type for better readability.
Yeah, I think I haven't stumbled on a lot of rules for that. I would say in general, you want to stay though with standard types. Arial, Helvetica, Times Roman. Georgia is a typeface that is a serif typeface. That is as complicated as you ever want to get. When you're labeling or providing information on charts and graphs, keep it very elementary. Give people fonts that they are used to seeing. This is not a time to get colorful. If you want to produce an interesting poster or something, maybe you do. But in this situation, I think you want to keep it fairly basic and show people type sizes, type fonts that they've used before.
Okay, so the like sans serif and just something real quick that we could look at.
Yeah, Arial, Helvetica, okay. I think is good. Times Roman. I'd keep it to be very familiar.
Okay. And another question is, what about the age of the data? I've seen some where they say don't really look at anything that's less than 5 years, if it's more than 5 years old, to try to stay as current as we can. Is that?
I think that's absolutely a good point. I think this is more of a question for epidemiologists and data analysts, but I think generally speaking, you want the most recent data that you can have, especially if it's a topic that's very current and you kind of know that the reports and the data from 5, 6, 7, 8 years ago have already kind of been digested and shared. The example I gave, though, was of some data that people weren't hearing about. All of the people who were showing up at hospital EDs because of dental conditions. So, you know, so I wouldn't sort of think that there's like a hard and fast rule. It's got to be 3 years or less. But obviously, the more recent data you can have, you know, the better.
Okay, thank you. And another comment, thank you, Matt. Very informative for us health professionals who are not epi people. And that is so true. I do want to give you, oh, go ahead.
No, there's so much potential for data to inspire action and help really get communities to focus on where they can really move the ball in terms of improving their health and wellness. And so I applaud that. I think, you know, we know EPIs do great work in bringing data to our attention. And so, you know, if we can translate it better and make it more impactful, it's gonna be a win-win.
Okay, thank you. I want to thank you all again for joining us and have a pleasant afternoon.